life thing, yeah. It's all about understanding, bro. You gotta understand what you're doing. You need a direction, bro. Good morning, y'all. Welcome to another day in my life as a doctor. Dr. Tochi here. I am here getting in. It is June 2nd, and I'm here for another hospice and palliative care rotation. If you guys are new, I am an internal medicine doctor and also a fellow in hospice and palliative medicine. I have about 6 months or 6 weeks of my fellowship left, and I have mostly inpatient rotations and one rotation at a nursing home. But basically, I'm here to do some consultations. Yesterday, we had about 3 new consults, 2 of which I signed off on, and they were hard cases, but overall, I think we did right by those patients and their family members. So today I'm going to see how we're going to progress other patients' care forward. I have a second-year family medicine resident working with me today, actually all week, and I'm trying to do as much teaching as I can because in the attending role that I'm going to be starting on September 1st, I'm going to be doing a lot of educational sessions. My goal for today is to actually improve my teaching skills and then also try to pick up some more patients and do some symptom management. Yesterday was more of like a goals of care discussion day as well as hospice discussions. So today I kind of want to flex my other muscles and try to, work on some more symptom management as I transition out of my fellowship into my attending year. So hope it goes well. Just finished rounding this morning, going over our list. We have about, I think like 16 people on our list right now, and we only got 1 new consult this morning, which is a little bit light compared to our normal baseline of maybe around 2 to 3, maybe to 4 new consults a day. We have a pretty big team, so the patients get divvied up pretty well, but 1 new patient came in this morning, and our attending was in clinic and on hospice call yesterday. So she's actually just going to be taking that patient. So I actually got no new patients for today, and I'm just going to follow up with my old patients from yesterday. Out of the 4 people that I was seeing yesterday, I'm only seeing 1 of them today. One of them actually died last night, so I'm going to be doing a bereavement call to the family and just kind of offering my condolences. And the other 2 I actually signed off on because we finished doing everything that we were consulted for. So the last one that I'm going to be seeing this morning, I'm supposed to meet a meeting up with the family in about 30 minutes to fill out a POLST, which is one of these, let me actually show you guys, one of these big pink pieces of paper. And if you guys haven't seen it already, I actually uploaded a video to my channel on what happens in emergencies and you don't have one of these. And if you want to actually get more information on the full, complete context of why these are important, you can go check them out, and I'll put them in the description box down below. But in a brief version, these are basically orders, physician orders to tell emergency services and hospital services what to do if your heart would have stopped and you would have died. There's 2 different routes. You can either say allow for natural death, and which is a DNR, and then there's also full code where you can do CPR, intubations, and the full resuscitative measures. So we actually had a full discussion with a family member over the phone, and we kind of went over the complete context of it. A lot of people get the DNR order a little bit confused and think that if we're doing DNR, we're not doing anything, and that's actually not true at all. And there's actually things you can do even though you are DNR, up until the point to where your heart stops and you would have died. So we had a full discussion about that, and we actually had a discussion about hospice as well. They're not quite ready for hospice, so we are going to fill out this form, and we're gonna probably discharge them from the hospital maybe like 1 to 2 days, maybe even today. So I'm gonna be meeting with them in about 30 minutes, and then after that I'm gonna go scour the ICU to see if there's anything going on in there, see if there's anybody that needs any consultations. And then after that, I'm going to probably do a little bit of studying. This morning I was going over prolonged grief, depression, and a lot of psychosocial / psychiatric conditions that can come with our field. And that's something that I'm doing a little bit of learning about. So I'll probably do a little bit of a recap at the end of the video to kind of show you guys what I learned. just finishing up lunch. I am going to give a call to this patient's family members so I can see if they're still coming today, because I was supposed to meet them around 10 in the morning to fill out this POLST, and they still aren't here. So I just want to make sure they're coming in so I can sign this, give it to the internal medicine doctor, and upload it to their chart, and then I can finally sign off of this patient and just close up this consultation. But that's one of the main things I have left for work today, unless another patient comes on the list. I think there was 2 patients that came on the ICU, but 2 of our other team members are going to be seeing them, so I'm not going to be seeing those cases. But I did run into one of my residency graduation buddies from 2 years ago. I graduated in 2024 in internal medicine residency, and it's kind of nice to catch up with him because I was able to see what he's been doing since he graduated from the residency program. For me, I did a chief year after my graduation, and then I also am doing this fellowship, so I'm 2 years off from what he's doing, and in those 2 years he's been working as an internal medicine hospitalist. And kind of catching up with him and seeing how he's doing, it's really nice because he bought a home, he's settling down, no longer renting, got a mortgage, is doing the whole adulting life. And it's kind of nice to see how things ended up for him, because I did meet him during the beginning of residency, and then seeing his progression to now becoming a full-time, full-blown attending, it was really refreshing to see. But it also kind of puts things in perspective for me, because I am still in this kind of trainee stage because I went back for fellowship. But if I didn't do that, I kind of think sometimes, I wonder what it would have been like for me if I just would have went straight and just became a hospitalist. And I think that I would have, still liked it. I don't think I would have loved it like I do now with this hospice and palliative care role that I'm in, mostly because I feel like for me, hospice and palliative care is not only about the patient, but I feel like I'm able to connect with them as a person. And I feel that palliative care just really humanizes the patients. We kind of learn them as a whole person, whether, it's physically, spiritually, emotionally, psychosocially. And I feel like I'm treating the person, not just treating the illness. So I feel like that's one of the main things that I really appreciate looking at this palliative care role that I'm going to be starting in September. And although I'm not doing like full-time hospitalist work for my internal medicine degree or license, I still do pick up those night shifts that I do that you guys have seen in these day in the life videos for my admitting shifts other in another town. So I'm still going to be keeping both licenses and maintaining both, because I feel like for me, I can never just really drop the entire internal medicine and just let the license lapse and expire. Because for me, I feel like not only does it amplify my practice in palliative care, but I also feel that why would I let a license lapse and expire, and something that I put so much work into during my med school years, during my residency. I just feel like it wouldn't be right for me, and I do generally enjoy the work, and I feel like it would also be good for me to keep up with that stuff, because internal medicine and family medicine, they're very applicable for the general public. So for my church, I started doing this health nugget series where I take whatever small tidbit of medical knowledge and I turn it into a digestible 5-minute talk during our sermons on Saturdays, and just to kind of make that a way to kind of give back to my community. So I do want to maintain both, and then I do want to keep on doing that for quite some time. Maybe later in my career, like maybe 30, 40 years from now, I'll just maintain only doing the palliative care role, mostly because the internal medicine role that I do right now as moonlighting or per diem work, it is a night shift position, and nocturnist work can be good, and it's really, I have a really nice setup at the hospital that I do the hospitalist shifts or for the nocturnist work, but I feel like there's kind of a shelf life for doing night shift work, and for me, I feel like it just knocks me out the entire next day. And for me, especially now that I'm going to be starting this new role in September, I am not going to be taking or picking up any extra shifts until I get fully acclimated and set in this new role. So I am really fortunate to have graduated and passed the licensing exam for internal medicine, and I'm hoping for the same for when I take the licensing exam for hospice and palliative medicine this November 10th. And I am looking to really just pass with flying colors, and then I will finally be done with the trainee role, which I've been in for quite some times: 4 years of college, 4 years of med school, 3 years of residency, 1 year of chief year, and then another year for this fellowship year. So it's a lot of years, over a decade of work. And for those of you guys that are watching this and are pre-meds or medical students or residents or fellows, it is definitely all worth it. And I just want to encourage you guys to keep on pushing and keep on thriving, because all the work that you put into it in your years of trying to get to your goal is going to achieve, and it's going to get there. And don't let anybody tell you differently.
Want you loving every side of me. Love the rhythm of your heartbeat. The way you pushing up on me. I can tell that you want me. Let me show you how it's gonna be. You don't need no other body. You don't need no other body. Only you can hold my body. Only you can hold my body. You don't need no other body, baby.
We are home. We are home. Thank God we are home. And I wanted to share with you guys just a little bit about the day and kind of close up the rest of this day in my life video. I really enjoyed today. It was very chill and it wasn't too much going on, but I was able to kind of close the loop with the old patients that I saw. I was able to talk to a family member and kind of just connect with them. A lot of the times in the hospital, we will have a patient that has capacity, meaning that they have the ability to make their own decisions. But a lot of times we'll have patients that are either demented or have some sort of altered mental status where they lose their capacity and they're not able to advocate for themselves because they can't really understand the full veracity of and everything that's going on in the moment. So oftentimes we'll have to reach out to other family members. And one of the main things that you can do that'll be really helpful for you guys and your family members in the future is to make sure that you have advanced directives filled out with a designated decision maker, also known as a durable power of attorney for health. And that is a legal decision maker. So once you sign someone to be your DPOA, the durable power of attorney for health, they are the first person that the healthcare society or whoever has to reach out to first to make any sort of decision. And oftentimes if you don't have advanced directives, you don't have a legal decision maker, but you can have a non-legal decision maker. Non-legal doesn't sound right, but you can have someone that is a decision maker for you that is not, signed into writing, where you have like a notary and everything and it's in paperwork. But essentially the biggest thing that you can really have is an advocate and a representative for your patient, because we need somebody to be able to make decisions for patients if they lose their capacity, not only because we need someone to make a decision, but also because the decision maker and the appointed person really understands the patient the best, and they know the patient, what they would want for themselves, and they are supposed to be a surrogate, in the name, a surrogate for what the patient would say in that moment. So we are able to talk to their family members. And one of the things is that oftentimes you have to ask the patient if it's okay to reach out to a certain patient. Just because someone is a contact in someone's chart doesn't mean that you just call them right away and just start talking to them about all their medical issues. Sometimes that just might be an emergency medicine contact. And one of the things, once you are okay or get the go ahead, that's when you can actually talk to them. So be careful if you guys are medical students, pre-medical students, residents. Don't just reach out to the first person you see in the chart, because sometimes you might share a bunch of sensitive personal information about their medical status that they don't want out there. So that's just something that we wanted to clarify, because there's a little bit of runaround where it's like, okay, can we call this person? Can we not call this person? And if they had advanced directives, then there wouldn't be all that runaround. We just call them right away. So other than that, it was a very good day. Tomorrow I have didactics, and I think tomorrow we're going to have lectures on hospice. I think we're also going to talk about, I can't remember exactly what we're going to talk about. I think we're going to talk about palliative extubations. No, that's actually not right. I can't remember exactly what we're going to talk about in our didactics tomorrow. And then tomorrow morning, before all that, around 9, I'm going to have a meeting with my future boss, and we're going to talk about things for the actual job that's going to be started in a few weeks. And then we're actually going to go over my note template. And in Epic, which is our electronic medical records, we have dot phrases and templates for our notes. And during my fellowship year, I actually created like a lot of my own smart phrases and smart lists, and kind of jerry-figured the already known template that is with the service. And it really helps for my efficiency. And the department heard about it, and they were like, hey, like, we want to see if we can make this universal, because note burden and note documentation is one of the biggest things that leads to healthcare provider burnout. And if there's anything we can do to kind of streamline that and make that quick, then that would be really beneficial. And that's something that I really want to prioritize when I'm attending, is being very, very efficient and giving high value care, and not being, dropping notes or writing notes into like 9-10 p.m. at night, because that's going to be very unsustainable, and I do not want that for myself. So other than that, I hope you guys enjoyed the day in the life video. Comment down below what you guys learned in the comment section down below from this video. Drop a like if you haven't already, and I'll see you guys in the next one. Peace. Have a nice day.